Hello. Okay. Very sorry, nampak gaya kita punya sesi ni agak haru biru sebab nampak macam you all tak ada tak prepare awal. Jadi saya akan cuba selesaikan sesi ni secepat mungkin. Sebab saya sebenarnya ada 3 meeting serentak ni. I got 3 screen in front of me right now. I'm going to ignore Dr. Tong Seng Fah. What I'm going to do, I'm just going to present the session using what we call the PowerPoint. Okay, I know it's going to become like a mini lecture, but just regard it as a exercise. Okay, so you all are going to go. We are going to go through the materials together. Later, after that, after we stop the session, you can go through the materials on the Microsoft Teams. Okay, so then we can you can try all the exercise on your own afterwards. Okay, I'm going to start with the desktop. The desktop is going to show you my PowerPoint. Okay, so this is my PowerPoint. Okay, I'm not sure whether you can see this or not. I'm going to check with Microsoft Teams. Okay, I'm going to show you the PowerPoint slideshow. Share. Can you see it now? Okay, very good. Okay, I know this is like a mini lecture, but you can try the exercise on your own afterwards. Okay, we just get this thing done over with as fast as possible because you all need data line. Tak semua orang ada data line yang banyak. Okay, so basically the title is Bones, Stones, Moons and Groans. Okay. The trigger is Miss Annie, a 46-year-old woman who presented to the A&E department with a sudden severe right flank pain radiating to the groin. Okay, she was noted to have a raised serum calcium level on a recent medical checkup. In the A&E, we are now the attending medical officer in charge. Okay, so basically acute right flank pain. So acute right flank pain, I don't know whether you can see this, but the flank is our side, bahagian tepi kita, belah kanan. So from here, it radiates downwards to the groin. Okay, so there's a key point here. Okay, as usual, if we reformulate, this is just a 46-year-old woman with acute right flank pain radiating to the groin and associated with hypercalcemia. Okay, the minute you hear right flank pain, the standard diagnosis, the most likely diagnosis is always renal stone. So the stone can started from your kidney and it came down through your urinary tract. Okay, I've had this episode 4 times already. I can tell you it is very painful. Okay, so hypothesis generation, as stated just now, most likely is renal stone. If it is at the kidney, we call it nephrolithiasis. If it is at the ureter, we call it urolithiasis. Okay, ureter is between the kidney to the bladder. Urethra is between the bladder to the outside. Okay, sometimes it could be due to back pain, or rarely it could be other things like appendicitis. As for the hypercalcemia, the most likely diagnosis is hyperparathyroidism. The rest are all what we call possibilities, but quite rare. So please take note of that all these things are listed there because of the mnemonics chimpanzee. That's why you see all these things listed there. But really, the most likely cause is renal stone and hyperparathyroidism. So learning issues you're supposed to do on causes of flank pain and anything related to the flank. Okay. So causes of right flank pain, we already stated now, kidney problem, back pain. It could be for the ladies, gynecological problem. It could be adrenal gland tumor. It could be a polycystic kidney disease. Okay. But if you look at this, okay, so we have the pain on the right side. So pain on the right side. So most of the stone from here came down through the ureter. Okay. So as it was coming down through ureter, this is quite small, and the stone is quite sharp and causing a lot of pain. There are also other nearby structures. Here you have the appendix on the right side. Okay. You also have the back. You can have back pain. It could be also gallbladder. The gallbladder is just in front of the kidney. And it could be also what you call cholelithiasis. Okay. So right side, there's a lot of possibilities. Okay. Why your PBL is so weird? Because it was designed around this mnemonics. Okay, chimpanzee. Chimpanzee C for calcium supplementation. You take calcium extra. Okay. H for hyperparathyroidism. I, where you are just lying down on bed, so there's bone resorption happening. M for multiple myeloma or mid-alkali syndrome, or you're on medication such as lithium, which is kicking out your calcium from your bones and replacing it with lithium. Or you could have parathyroid hypoplasia for P, A for alcohol, N for neoplasm such as breast cancer and lung cancer, Z for Zollinger-Ellison syndrome, E for excessive vitamin D, E also for excessive vitamin A, and sarcoidosis. So that's why you see your PBL is in fact focused around this, not really on a clinical presentation. Okay, so let's focus on the problem at hand. So we have a 46-year-old woman with acute right flank pain radiating to the groin and associated with hypercalcemia. Okay, the patient information sheet that was given to you all. Okay, you can download it from the Microsoft Teams. You can see that it stated that she was having severe right flank pain for 2 days. The pain was described as persistent, colicky, and radiating to the groin, associated with nausea, vomiting, and dysuria. Slightly relieved by paracetamol. Real life paracetamol does not work. You have to take constant. Okay. She also complained of constipation for the last 1 month. No history of trauma, loss of appetite, loss of weight, or fever. So there's unlikely to be cancer. So blood test indicates she had hypercalcemia. Everything else is not really significant except what the other one is she's a non-alcohol drinker. Okay. So what is pointing towards urolithiasis, colicky right flank pain, radiated to the groin, associated with nausea, vomiting, and dysuria. Okay, so if you have signs and symptoms of hypercalcemia, patient will be fatigue, lethargy, confused, thirsty, they have muscle pain, abdominal pain, nausea and vomiting, anorexia, constipation, and palpitation. So if you have palpitation, it may not be your boyfriend passing by. It could be having hypercalcemia. So you could also have an altered mental state. You are passing out a lot of urine. This one is diabetes insipidus due to adrenal gland problem. Or it could have oliguria because there's kidney damage. Okay, what happened? The stone block the urine passing out, so you end up with acute kidney injury. It could have hematuria because if the renal stone is coming down. Okay. You could have myopathy, muscle pain due to the calcium, reduced bowel sound also due to the calcium, arrhythmias also due to the calcium, dehydration, and pancreatopathy. This one you have to look it up. Pancreatopathy, you have to look it up. It is on the eyeball. So for the learning issue number 5 is about the calcium homeostasis. So calcium concentration in the blood is regulated by calcitonin and parathyroid activated calcitriol. Where does calcitriol come from? It came from the kidneys. It stimulates the cells releasing calcium from the bone, increase uptake to the GIT tract, and increase the reabsorption in the renal tubule. So calcitriol, they want more calcium to be in the blood. So that's why they ask the bone to release the calcium. Okay, that's why they increase intake from the GIT tract, and that's why they reabsorb in the renal tubule. Calcitonin is released from the thyroid gland and it stimulates calcium deposition in bones and reduce uptake in the kidneys when calcium is removed to urine. So calcitriol and calcitonin has got different effect. Okay, so calcitriol from the kidneys, calcitonin from the thyroid gland. Okay. Okay, here's another look at it. Again, another diagram about how the calcitriol synthesis happen and how the calcium is taken up and released in the body. So why do we need calcium? Calcium is important for everything, even for your muscle to move. Okay, it acts as external guard of the sodium channels. It is necessary for your normal neuronal function. It acts as an important intracellular second messenger. It is necessary for muscle contraction and also necessary for blood coagulation. So it is a very important cation for the normal tissue function. You can look it up for the blood coagulation. They cover at many different places of the blood coagulation process. That's why calcium is very important. Okay. The other issue is learning issue 7 is about phosphate and calcium metabolism. Phosphate is very important for you because calcium by itself is very fragile. Sorry. So the phosphate will allow you to have a much stronger bones, okay, a much stronger teeth. Without phosphate, your bones are fragile, your teeth are also fragile. Okay, so this one explain about how the phosphate and the calcium interact with each other. Okay, please take note, they have an inverse relationship between the plasma phosphate and the calcium concentration. Okay. So for the patient information sheet 2, the only thing of interest is the patient has tenderness on the right flank. Okay. So patient is alert, conscious, moderately distressed because of the pain. The rest are all okay. The heart rate is increased due to the pain, and that's it. When we look at the patient information sheet 3, the full blood picture abnormal, calcium level slightly high. Okay. The rest okay. Creatinine on the higher side. Of course, the creatinine here, the cutoff point is too low. They say only 82. Okay. But this one, what they're just trying to say is that patient has renal impairment due to the renal stone and thereby causing the urea to be increased and the creatinine also to be slightly increased. Which one is more likely to be increased? Creatinine is more likely to be increased compared to urea. Okay. Alkaline phosphatase just indicate bone resorption. So there is increased bone resorption. That's why the level is quite high, 106. Okay. The parathyroid hormone you can see is quite high. It's 75 microgram per liter. Okay. So does the X-ray shows? It shows a stone here, quite big. Okay. And you can see here, another one here, down here, the stone has really come down. Okay. So you got two stones here, A and B. So when they do the ultrasound indicate an enlarged parathyroid gland. Okay. So this one is enlarged. Okay. This whole thing is a thyroid gland. This one is enlarged. So you got 4 parathyroid gland. 1, 2, 3. 4. There's a fourth one here. Okay, you can see that on the right side here, there's increased uptake at the right thyroid lobe. So the lesion is this. So the lesion is this one that is affected. So the final diagnosis is patient having nephrolithiasis due to hypercalcemia secondary to primary hyperparathyroidism. In fact, this is wrong. The word, you cannot use nephrolithiasis. Nephrolithiasis if the stone is still up there in the kidney. You saw on the X-ray, the stone came down already. Okay, the stone came down already. Here, 1. So you got 2, 1 and 2. So this nephro and urolithiasis. Yeah? So patient has nephrolithiasis and urolithiasis. So these are the lab investigation. The whole point of the lab investigation is to determine the cause. So when you have this diagram that I show you, basically for you to decide what is the cause of the problem. So in this case, you can see that patient have hypercalcemia. The parathyroid hormone is higher. Patient has hyperparathyroidism. So most it could be related to hypercalcemia. Therefore, you have to check for all the other things. Okay. Okay. So this is the picture of the thyroid gland. Okay. This whole thing, the brown thing, is the thyroid gland from the back. So you can see here, the parathyroid gland is underneath the thyroid. So you got 4 there. 1, 2, 3, 4. Okay. So causes of hyperparathyroidism, you got primary, secondary, and tertiary. So primary, we have the parathyroid adenoma, carcinoma, okay, familial hypocalciuric hypercalcemia, so forth. Secondary for renal failure or low calcium intake or inhibition of bone resorption. Okay, so please take note of that. Okay, so as you can, they ask for the pathological features of carcinoma parathyroid. I'm not going to cover that. You all can cover that on yourself. But I just want to show you this picture. When you do all this special scan, this special scan will show that there is increased uptake of the dye, causing the parathyroid gland to be highly visible. Okay, this is how they decide based on the special scan. Okay, and sorry. So what is the problem with hypoparathyroidism? Basically, hypoparathyroidism is overactivity of the parathyroid glands. The glands secrete parathyroid hormone. Okay, we need the parathyroid hormone to maintain the calcium, phosphorus, and vitamin D levels. And this one, all these things will lead to problems. So, what is the complication? So, you end up with nephrolithiasis, you end up with urolithiasis, you end up with heart problem, you end up with constipation, and so forth. Okay, so you can look it up for yourself. Okay. So finally, patient information sheet 4. Patient was immediately started on intravenous fluid for the management of dehydration. Then you need to flush out the calcium, so they gave the patient furosemide. And they had extracorporeal shockwave lithotripsy to remove the kidney stone, which is not really correct. If the stone is quite large, you cannot do ESWL. If the stone is quite large, you have to do what you call PCL, percutaneous lithotripsy. So they have to cut a hole in the back and remove the stone from the back. Okay. Here, in this case, if say patient underwent parathyroidectomy, the abnormal tissue was removed. Okay, and immediately the calcium level normalized. Okay, so this is the conclusion. This one just to show you what is ASWL. I had ASWL done on me way back in 1999. Okay, so you lie down and you wait for the machine to give you sound blast to break up the stone. Okay, and with so how do you manage for hyperparathyroidism? You already saw just now. You diagnose, and then you decide whether you want to go for surgery or not. You want to go for surgery, you do the ultrasound, you do the imaging, then you operate, then hope for the serum calcium to come down. If you don't want to go for surgery, you want to go for medical, you hydrate the patient well. Okay, you reduce the calcium intake. If the patient is having osteoporosis, you give biphosphonate treatment. Okay, monitor the serum calcium every 6 months. Monitor the urinary calcium excretion, and you do the DXA every 12 months. Okay. All right. Okay. So I'm going to cancel the screen sharing. Okay. All right. So right now the session is quite bad. I'm not sure whether you can see me or not. Okay. Boleh bro eh. Terima kasih. Nanti boleh bagi markah lebih. Alright. So thank you very much for ni. You go ahead and do the exercise on the on the on the wall. The marks will be based on the exercise that you do on the wall. Okay, on the channel there. Okay, and we'll see. If you discuss among yourself whether you want to present online. If you want to present online on Thursday, we can have the same session again. Okay. All right. Thank you. Goodbye.